We are now going to hear from Dr. Shana McCormack. She attended medical school at Harvard Medical School and Massachusetts Institute of Technology. She is currently an attending physician and scientific director of the Neuroendocrine Center in the Division of Endocrinology and Diabetes at Children's Hospital of Philadelphia, also known as CHOP, where she also serves as a member of the clinical research team for mitochondrial medicine. To add to that, Dr. McCormack is an assistant professor of pediatrics at Perelman School of Medicine at the University of Pennsylvania. She has a clinical interest in patients with endocrine dysfunction related to individually rare metabolic disorders such as primary mitochondrial disease, Friedreich's ataxia, and lipodystrophy. Dr. McCormack, thank you for being here today. I will go ahead and turn it over to you.
All right. Thank you so much, Nicole, for the kind introduction, and to the MDA for the invitation to speak. I really appreciate it. Nicole, I'll just ask, is the screen showing up okay for you?
It is. It looks great.
Wonderful. Well, then we'll get started. So thanks again. My name's Shana McCormack. I'm going to be talking about, I think, Nicole, did you advance that for me? Or
no.
did that just miraculously go? All right, here we go. Yeah, so I have some exciting slides and they're kind of got a life of their own. So I'm going to be talking about endocrine disorders in mitochondrial disease. And we'll go ahead and go to that first slide since it really wants to. So this group well knows that mitochondrial myopathies affect endocrine function in lots of different ways. So this diagram here shows all of the different endocrine organs that can be affected. So part of what's neat about being an endocrinologist is there's so many different organs to assess. So there's the hypothalamus and pituitary gland, which make a lot of different hormones. There's the parathyroid and the thyroid glands in the neck, the adrenal glands that make cortisol, the pancreas that affects risk for diabetes and blood sugar problems, the ovaries in women, and the testes in men that make sex steroids. So all of these and more have the ability to be impacted. And endocrinology is a very practical discipline. For many of these hormone deficiencies or sometimes excesses, we have medical therapies that can help. So we really try to make diagnoses promptly in affected individuals because we think we can help them feel and function better. So my goal for you today is not to go over every slide comprehensively, but instead to give you a brief flavor for each of the kind of disorders that exist and share some resources so that you can learn more. So as I mentioned, endocrine disorders are both prevalent and treatable. This paper is from one of our trainees, Iman Al-Ghadi. She described endocrine disorders in primary mitochondrial disease using the North American Mitochondrial Disease Consortium, and many of you may participate in this endeavor to collate the experience of individuals with mitochondrial disorders. So this data set includes 404 individuals with molecular diagnoses of mitochondrial disease. And what Iman found was that endocrine problems are common. So one problem was atypical growth, meaning short stature, failure to grow during puberty, and difficulty with sexual maturation was really common, present in almost half of individuals. Diabetes, as folks know, is a complication of a mitochondrial disease for many. That was present in around 13%. Hypothyroidism was also common. Other endocrine disorders that weren't collected systematically, but that folks noted included hypoglycemia or low blood sugar, adrenal insufficiency, which is cortisol deficiency, and then hypoparathyroidism and impaired bone health. So glucose homeostasis or sugar metabolism is the one I'd like to address first, because this one we get a lot of questions about. So this is a schematic about how I think about blood sugar in individuals with mitochondrial conditions. And on the y-axis here of this graph, you have blood sugar levels that we measure in the blood. Blood sugar levels are problematic if they're too high. They're also problematic if they're too low. And so there's a range of healthy blood sugars where people feel and function best. Excuse me. And I've outlined in green here folks who are healthy, and in red folks who have mitochondrial disorders. And what the x-axis here is nutrient availability, meaning whether or not an individual is fasted, meaning not having a lot of nutrition around, or has more nutrition than they need. And my experience is that folks with mitochondrial disorders have a narrower sweet spot, if you will, for maintaining lower normal blood sugars. In other words, They are more likely to develop low blood sugars when nutrients aren't available enough, for example, even after brief fasting for some individuals. And also blood sugars can go too high when nutrition is in excess or for other stresses when they're around. So hypoglycemia, this is something we hear about all the time, and so I'm starting with it. And you see this schematic that's posted in our resident room that says often but not always keep calm and push D10, meaning dextrose containing fluids in the hospital for an individual who has low blood sugar. Replacing blood sugar if blood sugar is low is obviously one way that works to restore normal blood sugar in many individuals. So symptoms of low blood sugar can include feeling sweaty, shaky, or pale. And often, which is key, those symptoms are reversible when carbohydrate is ingested. So our first steps when we are evaluating someone with hypoglycemia is to look for treatable causes. We'll talk more about cortisol deficiency in a moment. That's a hormone deficiency. Malnutrition is very important. If an individual isn't nourished enough, that can be a reason the blood sugar goes low. Treating, so having a treatment plan readily in place is important. I have reversing catabolism here. So catabolism means that when there's not enough fuel available for blood sugar, the body breaks down fat and sometimes muscle for energy. And often folks with mitochondrial disorders don't tolerate that well. So our treatment aims at reversing that process. And ideally, if for folks with hypoglycemia, we have an emergency plan in place and a letter in place that folks can reference for when they're ill. In other words, if someone's sick, what do we do to monitor their blood sugar? And if it's low, what do we do to rescue the blood sugar, and how do we maintain blood sugar in a safe range for this individual? So making that plan ahead of time helps decrease the chances that blood sugar is low for a long time. I mentioned fasting and ketones. Just to help you think a little bit more, hypoglycemia is actually not one entity. It comes in different flavors. And how we approach patients who are affected really depends on the cause. And some folks actually have, even the same individual can experience different kinds of hypoglycemia. So as endocrinologists, we often divide hypoglycemia into two kinds, into ketotic, meaning ketones are present, and non-ketotic forms of hypoglycemia. So many folks are familiar with that term ketones, but for those who are not, I'm just going to review it. So this is a schematic of energy metabolism when stores are adequate, meaning when someone is fed, our bodies use mostly carbohydrate. And then we don't make ketones. Ketone production is suppressed because ketones are a breakdown product of burning fat for energy. So when our energy stores are limited, meaning when we've mostly run out of carbohydrate, we start burning mostly fat and we produce ketones. So often, but not always, folks who experience fasting hypoglycemia can become ketotic. So for some people, monitoring ketones can help because it's a sign that they're running out of that important carbohydrate for energy. Also, what's so-called reactive hypoglycemia, meaning the hypoglycemia that occurs with meals. So after blood sugar goes up, there can be a brisk insulin response, and the reaction is the blood sugar becoming low several hours after a meal. Typically, ketone production is suppressed in that setting because it's in the fed state, and that hypoglycemia is non-ketotic, and our approach to treatment can be different. It's really important to note that some individuals with metabolic disorders, particularly mitochondrial disorders, actually can't produce ketones, can't effectively burn fat for energy, and ketones also, I'll mention, are a source of energy for the brain. So it's really important for us as endocrinologists not only to think about ketotic or non-ketotic hypoglycemia, but to know for a given individual whether or not they actually have the capacity to produce ketones, because that helps us come up with the best monitoring and management strategy. So I'm showing you some data from Patrick Hanley. He's an endocrinologist practicing. He did his fellowship training now at CHOP, and he's at Nemours, and he's got a manuscript in preparation about hypoglycemia in individuals with mitochondrial disorders. And at CHOP, for folks who have hypoglycemia, we sometimes admit them for controlled fasting studies. And you might ask, because folks with mitochondrial diseases are often advised not to fast, which is good advice, for what reason we do this. often we do this to answer very specific questions. So for folks who, for example, are on tube feeds overnight, but their nutrition is improved and they want to assess whether or not it's safe to hold those overnight feeds. They want to see his blood sugar in a safe range. We admit them to the hospital and monitor them closely to answer that specific question. So what Pat did was take all the inpatient fasting studies that were available to us at CHOP for individuals with mitochondrial disorders, either suspected or confirmed, and compared them with children with an entity called idiopathic ketotic hypoglycemia, meaning children who apparently are otherwise healthy but seem to have a shorter fasting time. And what this parameter shows is the how long they were able to safely fast, and you'll see the duration was longer in individuals with ketotic hypoglycemia as compared to some individuals with mitochondrial disorders couldn't safely fast even for a couple of hours. And also ketone production overall was less. So people with mitochondrial disorders differ from each other, but in general, I think of them as folks sometimes who can have shorter fasting tolerance and who may have impaired ketone production. So both those things are important to bear in mind. When we see someone in clinic and we're thinking about our initial evaluation for hypoglycemia, when we suspect that it's present, we first advise that folks check blood sugars when they're symptomatic, so when they suspect they might have low blood sugars. And also, if they do fast, we say after the longest usual fasting interval. And for many people who don't eat overnight, that will be first thing in the morning. Our typical goal blood sugar is at least 70 milligrams per deciliter, and at less than 50, we consider that as an emergency because the brain really needs blood sugar to be safe. We also have folks check ketones. And one point I like to make here is that ketone measurements in blood are more accurate than urine for at least two reasons. One is, well, three reasons. One is urine is difficult to get sometimes, right? But also the value in urine depends on how concentrated or dilute the urine specimen is. But also the form of ketones that's present in a urine when you use a dipstick is actually different than the form that you detect in the blood. And we think that the form that you detect in the blood is one that's more readily made by individuals with mitochondrial disorders. So this is the one that I prefer. This picture shows a schematic of how to test ketones in blood. And ketone value of less than 0.6 is considered trace, so low. And values 3.5 and higher are considered quite large, and in between is in between. So based on the initial surveillance is when we develop a plan with folks, how often should they monitor their blood sugar? Should it be every day or multiple times a day, or perhaps only when they're ill? What do we do if blood sugar is low? When do we seek emergency care? And how do we provide a safety letter so that folks know how to take care of them? And this guidance, I imagine you've been provided in lots of other contexts, but watching out for NPO status. So folks have to have a procedure, being really thoughtful about their nutritional status and to avoid excess fasting in particular, or in everyone really, but in particular for folks who struggle with hypoglycemia. So switching gears to the other side of blood sugar, diabetes, so high blood sugar. I've titled this slide Mitochondrial Diabetes Beyond Type 1 and Type 2, because I think one important point is that individuals with mitochondrial disorders have a diabetes that's its own flavor. And actually individuals differ between each other and also can differ over the course of the lifetime. So when we think about diabetes broadly writ, kind of all kinds of diabetes considered, there are at least 30 million adults in the US with diabetes and many more with what is called prediabetes. And the Center for Disease Control has this diagnostic framework. They say, okay, around 5% is so-called autoimmune or type 1 diabetes. That's typically childhood onset where the immune system, for reasons we don't entirely understand, attacks the pancreas and the person can't make enough insulin to control blood sugar. So that's type 1. Type 2, which is the vast majority of the rest, is heterogeneous. And we say potentially weight related, potentially related to excess weight gain or activity, but not entirely. Gestational diabetes occurs during pregnancy, and then there's other. So this framework we find as endocrinologists works really poorly because there's so many different other flavors and kinds of diabetes. So I'm going to share how I kind of think about it in just a moment. But this is relevant to this group because mitochondrial diabetes, represents to me the tip of the iceberg. So there's a few we found in our paper around 13% of folks who meet our traditional diagnostic criteria for diabetes, but there's far more who have some abnormalities in glucose metabolism somewhere along this spectrum. So this is another schematic here to show you what I'm thinking about. So if we've got everyone in the country, right, and there's got the blue individuals that don't have diabetes, the red that kind of have other forms, and then the green might be the individual with a mitochondrial form of diabetes. By some estimates, and Dr. Kara, who just spoke with you, wrote a really nice paper on this question. Some folks estimate up to 5% of so-called typical diabetes may actually be mitochondrial in origin. Diabetes is common in some mitochondrial DNA deletion syndromes, for example, Curran-Sayer. It also occurs in individuals with nuclear mutations also, and I've listed some examples here like Paul gamma or RM2B. In children with mitochondrial disease, my experience is diabetes can have a more acute onset with insulin deficiency. So something called diabetic ketoacidosis can be a presentation, and that's when blood sugar is high, and because of lack of insulin, the body produces a lot of ketones, which are acidic, which can make the child very sick. In adults, diabetes can be more insidious, but still, in comparison to so-called typical type 2 diabetes, it can occur at a lower body mass index, at earlier age, and the complications that happen are different. More involvement of the kidney, more involvement of the nervous system, but perhaps less retinal blood vessel involvement than typical type 2 diabetes. So I think it's worth considering each individual themselves with respect to these important parameters. So I'm going to share with you a case that we took care of, just to give you a flavor of one way in which mitochondrial diabetes can present. So this was a 6-year-old who first developed excess urination and thirst. Those are really key symptoms of high blood sugar, because when the blood sugar is high, it spills into the urine and it causes a really increased urine output. And then thirst follows from that because the individual is becoming dehydrated. So when blood sugar was checked randomly, it was 629. So for folks not familiar, a random blood sugar above 200 and these symptoms is consistent with diabetes. A confirmatory lab that we do is hemoglobin A1C, which is an estimate of average blood sugar over around 3 months. This individual's was 9.6. To give you a sense, the reference is less than 5.7%. The American Diabetes Association defines a goal of around 7% as reasonable glycemic control for individuals with diabetes, but also emphasizes that that goal needs to be individualized to balance carefully the risks of blood sugar that's too high or blood sugar that's too low. When this individual presented, she did not have any ketones, so that was good. She also didn't have any anti-pancreatic autoantibodies, meaning no sign of what we think of as typical type 1 autoimmune diabetes. We started insulin treatment for her, and in subsequent years, it was noted that she had ptosis, decreased tone, higher lactate, retinal findings, retinal dystrophy, and her EKG was notable for heart block. So she's subsequently been diagnosed with Curran-Sayer from mitochondrial DNA deletion. And I'll thank Amy Goldstein, who collaborates with me in the care of this patient, for this case summary, as well as the diagram of mitochondrial DNA where the various deletions are illustrated, including those that cause Curran-Sayer. So when I think about mitochondrial diabetes and why it occurs, there's really 2 main reasons. The first, which has been recognized to be around for a long time, has to do with the pancreatic beta cell that produces insulin. So many people don't know this, and I didn't even know this until medical school. We think about the pancreas making insulin in response to sugar, and it kind of does, but it kind of doesn't. The pancreas makes insulin in response to ATP produced by the mitochondria, and that's what this diagram shows here. So for those of you interested in the biochemistry, glucose enters the cell, and then the mitochondria does its magic and produces ATP, and ATP leads to the secretion of the insulin granule. So this is an important coupling that in folks with many mitochondrial disorders is not working well. So even in the presence of glucose, the fact that not enough of that glucose gets used to make ATP means that insulin secretion is deficient. And that's one main reason that folks develop diabetes. And that's been recognized for some time. The other phenomenon that we study is the role of muscle insulin resistance, or resistance to insulin in other parts of the body. So insulin's job is to cause the tissues of the body that need insulin to take it up for energy. And it turns out that in some folks with mitochondrial disorders, the organs are resistant to insulin's effects. And so our group, just a brief foray into research, has been investigating how do we think more about the role of muscle in mitochondrial diabetes so that we can understand better about how to treat it in that way. So for the purposes of this quick diversion into research for your interest, I'm going to show you a picture of the phosphocreatine shuttle. You guys may have heard of this. This is a biochemical reaction that occurs in the skeletal muscle. So phosphocreatine is illustrated here, I think of as a storage form of ATP. It's like the bank account when you need a lot of energy quickly. As for example, if you were going to exercise. So when you exercise, your body, your muscles in particular, which is shown here, use up ATP. And to regenerate ATP quickly, it uses the high energy phosphorus from the phosphocreatine. So that's, for example, if a quick burst of energy like sprinting for a bus. So when phosphocreatine is used up and turns back into creatine, when the exercise is over, it needs to get regenerated and phosphocreatine needs to get produced. And what does that is the mitochondrion of the muscle. So as the mitochondria, a healthy mitochondria churns out ATP, creatine gets turned back into phosphocreatine, so you have the storage form ready for the next time you need to exercise. And we take advantage of that in an imaging technique called creatine chemical exchange saturation transfer that we use in our research facility. And we've been fortunate, many folks have volunteered for our study testing out this research imaging technique. So I'm showing you briefly an example of the results that we get. So here's a 21-year-old healthy individual and a 21-year-old woman with a mitochondrial disorder. And the colors that you're seeing here are measurements of free creatine in the muscle. And this is a cross-section of the muscle where the shin bone is at the top and the calf muscles are at the back. And the first row of images in each sequence are at rest. So creatine levels at rest are typically low. Then after exercise, because phosphocreatine is used up, creatine levels increase. So each of these pictures is taken 24-ish seconds after the exercise is stopped and in sequence, right? So we can see how well the muscle recovers, how quickly phosphocreatine is regenerated. And that recovery trajectory towards baseline is shown down here in the graph. And we can see how quickly do we return to baseline. And in this individual who's healthy, it happens quickly. In this individual who has mitochondrial disorder, it happens more slowly. And that is how we quantitate the degree of oxidative phosphorylation capacity in muscle. And we've shown in individuals with one particular form of neurodegenerative condition, Friedreich ataxia, that affects muscle mitochondria, that this is related to the insulin resistance that they experience. So turning back away from research for a moment, just revisiting the symptoms of mitochondrial diabetes, or any diabetes really, that are related to high blood sugar. So I like this schematic. It's from our colleagues in the UK at the NHS, the National Health Service. So folks who are excessively thirsty, and as a result of that increased urine output, peeing a lot, being more tired than usual, losing weight unintentionally. All of this should prompt consideration of diabetes. And I've added the emergency conditions down here, either ketoacidosis or something called hyperosmolar hyperglycemia, when the blood sugar concentrations become so high themselves that they're dangerous for the body. So there's a lot of ways to treat diabetes, and I am not going to take you through this entire schematic. This is the American Diabetes Association 2021 guidelines for intensification. I'm showing you the schematic, again, not to take you all the way through, but mainly to share that there are so many more options for treating diabetes than there used to be. Even when I started training as a fellow, the number of medications has increased a lot, which is fantastic. And if you care to look at the details here, based on different patient characteristics, for example, how much high blood sugar they have, do they have kidney disease, do they have heart problems? Is cost an issue? You're invited to choose different medication strategies for treating their diabetes, which is terrific. But I'll spare you looking in detail. There is no mitochondrial diabetes flow diagram here, right? So the usual guidelines don't speak to the more rare forms of diabetes. So we have to use our judgment and use what we know about the pathophysiology of mitochondrial diabetes and what we know about each person. So reasons for insulin therapy, which has been the mainstay of many forms of mitochondrial diabetes, would be if someone experienced diabetic ketoacidosis, because insulin is the best way to prevent that from happening again, or significant hyperglycemia, meaning persistent high blood sugars above 200 that can cause dehydration or weight loss, which we don't want. Novel interventions, some of these new medicines that are available beyond the scope of time that we have for this talk. There's not a whole lot of data yet in mitochondrial diabetes, but I think it's important to consider some of these in the right candidates in collaboration with your endocrinologist. We always advise to avoid low blood sugars and to test for and avoid ketones. Also, it's important to use technology. You know, historically, folks with mitochondrial diabetes have shared that sometimes they weren't offered the same continuous glucose monitors or insulin pump therapy that others with more typical forms of diabetes were. But that's changed over time, which makes me really happy because the technology is really valuable. So one technology that we really like is something called a continuous glucose monitor that helps measure blood sugar continuously. So this is Nick Jonas, who has type 1 autoimmune diabetes, not mitochondrial diabetes, but I liked the photo of him showing his continuous glucose monitor there. I always mention to folks with vision or mobility impairment, there are forms of insulin delivery systems for those folks. Also, there's newer forms of glucagon, which reverses an insulin-related low blood sugar, including an intranasal administration, meaning no shot. So if you have diabetes requiring insulin and you don't have this yet, I recommend getting it. We talked about technologies, and also there's amazing developments in the works about automated insulin delivery systems that I'll share in a second. So this is an automated insulin delivery system. I won't go into detail, but what it does is senses blood sugar and then adapts the insulin algorithm in response, which is just a really exciting direction for therapy. So to summarize mitochondrial diabetes, insulin secretion requires mitochondrial ATP production, and insulin resistance can for sure occur. So it's really important that folks are aware of symptoms, and now this entire group is. Also that they are screened annually. We typically include an A1C and random blood sugar at minimum, and perform testing, more testing in folks who are at higher risk. We manage based on the person's physiology, including their ketone measurements, and select the medications based on individuals' comorbidities and their preference related to side effects. And we also think a lot about technology. All right, so switching gears away from sugar towards stress. So adrenal insufficiency, folks may have heard of. So this is our kind of textbook illustration of the adrenal glands and their production of cortisol, which is a hormone that's really important for keeping blood sugar up and blood pressure up during times of critical illness. So symptoms of adrenal insufficiency, meaning not enough cortisol production, is low blood sugar, low blood pressure, sometimes low sodium levels, especially when folks are experiencing stress. And I always highlight here, mitochondria are critical for steroid hormone synthesis, and so it's not surprising to me that cortisol deficiency manifests in some of our patients. The other kind of adrenal insufficiency that's important can occur if somebody has been treated with steroid medication, because then their bodies stop making the typical amount of cortisol until that medication is weaned off. So I always make that reminder for folks who may have needed steroid medicine for other conditions, for example, asthma. Our bodies need cortisol a little bit every day and then more when they're sick. So doses of prednisone around 5 milligrams is what is a kind of physiologic replacement for adults, meaning their kind of day-to-day cortisol need. And a prednisone dose that's higher, around 20 milligrams daily, provides what we call a stress dose in adults, meaning a higher dose that helps cover them or keep them safe in illness. And this schematic I'm showing you here to remind me to mention to you the diurnal profile of cortisol production. So cortisol levels are lowest during sleep here, and then increase right around 7 or 8 a.m., and then decline over the course of the day through the night. And that becomes important to think about when screening and also for managing individuals with adrenal insufficiency. So we often get asked who needs testing for adrenal insufficiency. So I mentioned having received high doses of steroid medication for a long time should definitely trigger consideration. We say individuals with suggestive symptoms, so I mentioned some of those earlier, warrant testing. Sometimes individuals who are very, very sick, in particular in ICU settings, where we wonder if adrenal insufficiency is the cause for their persistent illness. Sometimes empirics, meaning without waiting to kind of make a definitive diagnosis, sometimes stress steroids are given for safety in ICU settings. And I'm highlighting, a paper that recently came out of CHOP for our group, where one of our intensivist colleagues described PICU experiences for individuals with mitochondrial disease and found that levels of mortality and illness were substantially increased. So we get this, including this finding, to kind of emphasize the importance of considering this diagnosis, especially in ICU settings. So this is an illustration more getting down to the cellular level of the different hormones that the adrenal gland makes. So I've been talking a lot about cortisol, that's glucocorticoid, that's in the middle here. But adrenal gland also makes other hormones too. It makes mineralocorticoids. So a medicine for folks who are missing this particular kind of adrenal hormone, it would be fludrocortisone. The adrenal gland makes androgen, so hormone with male-like effects. And the very middle of the adrenal gland, the medulla, makes catecholamines. Those are our fight or flight responses. So the way we screen for adrenal insufficiency is typically we ask for an 8 a.m. value of the cortisol hormone, also the ACTH, that's the pituitary hormone that governs adrenal steroid production. Sometimes we do something called provocative testing, more involved testing to see about the capacity of the adrenal gland to make cortisol. And then if folks have deficiencies, we need to understand, do they need glucocorticoid only? Do they need glucocorticoid and mineralocorticoid? Do they need some every day? Do they only need some with stress? And we have to be really thoughtful about not giving too much because there's side effects of higher doses of steroids as well. All right, so switching from cortisol to another really important hormone system for safety, that's calcium. So calcium levels are regulated very closely in the body by a hormone called parathyroid hormone. So that's illustrated here. These 4 circles represent the 4 parathyroid glands, and they're called parathyroid because they live like essentially nestled within the thyroid gland themselves. And PTH is responsible for keeping calcium levels up in the body. And that's really important because calcium is important for muscle contraction, including the heart, one of the most important muscles in our bodies, right? And the diaphragm. Low calcium levels can be associated with muscle weakness, abnormal heart rhythms, and with seizures. So this is a really important electrolyte to keep an eye on. And some individuals with mitochondrial disorders have what's called hypoparathyroidism, meaning they don't make enough of this hormone PTH that has multiple actions at the level of the bone, at the level of the kidney, and at the level of the gut to defend or keep up the body's calcium level. So PTH reclaims calcium from bone, helps reclaim calcium from the kidney, and helps the body absorb calcium from the gut. So the symptoms of low calcium levels I mentioned, folks who have low magnesium levels, potentially related to mitochondrial kidney disease, can also have what's called PTH resistance and have trouble keeping up their calcium levels. So when we evaluate folks for potential problems with calcium, we also include a magnesium level and typically a phosphorus as well, because those travel together. This is a defect that's really important to identify because we absolutely can treat hypoparathyroidism with replacement. And typically that includes calcium as well as an activated form of vitamin D that helps the body absorb calcium from the gut more effectively. So the way, this is summarizing kind of some of the points I made on the previous slide. When we suspect somebody has low calcium levels, or when we know they do, or if they have a condition like Kern-Sayer, for example, where we know they're very at risk for these, we measure periodically blood calcium, magnesium, and phosphorus levels. We measure parathyroid hormone at the same time, and one teaching point that's really important here is that we interpret PTH in the context of what the calcium is, meaning we can't look at a PTH level in isolation. We have to say, what's the calcium? Because if the calcium is low, PTH should be high. If the calcium is high, PTH should be low. The PTH should be whatever it needs to be to bring the calcium back towards normal. We look at urine calcium, creatinine, and phos, because how the kidneys are handling calcium gives us a sense of how well this system is operating. We also do an EKG because we're concerned in folks with calcium problems about abnormal heart rhythms, and we want to find those early. Another important point to make here, some individuals only have problems with low calcium level during illnesses. Others have problems with low calcium levels all the time. The treatment for hypoparathyroidism, as I mentioned, is calcium, the activated form of vitamin D, and which is calcitriol, and cholecalciferol, which is the storage form of vitamin D. So this is an important distinction. Calcitriol meaning the activated form of vitamin D, which is responsive to PTH, which helps bring calcium levels up. If someone doesn't make PTH, well, then they can't activate vitamin D. You have to give them this active form. In most everyone else who have vitamin D deficiency, for example, we give cholecalciferol, the storage form. And we are asked often, gee, well, if this is the activated form, then why don't you give the activated form to everyone? And that is because we want to let the body activate vitamin D when it needs to. And the best way to do that is to use the body's own PTH system that's functioning well and make sure there's enough stores around. It's really for those folks who don't have a functioning PTH that we need to use this activated vitamin D, because there's downsides to giving too much calcium, and that particularly can include kidney stones. So we also make what are called stress plans for individuals. So stress plans mean if they're sick, they often need more frequent monitoring of blood calcium and increased doses of replacements like calcium and calcitriol to keep those calcium levels normal. And this is another situation where we really watch out for NPO status, because folks can be sick and vomiting, for example, and vulnerable for their calcium levels to fall. So switching gears again towards growth. This group well knows that lots of activities in life require energy, and growth is chief among them. And as an endocrinologist, we think about this all the time. So this schematic that I'm showing you right here, mitochondria are critical for transforming nutrition into useful energy that children can use to grow. So this is the energy requirement in calories per kilo, meaning kind of weight adjusted calorie requirements per day. And this is age on the x-axis, going from age 1 all the way up to 18 for both girls and boys. And you notice that especially in infancy and in young kids, energy requirements are really enormous relative to body weight. And part of that reason is because it's sustaining typical growth. So I mentioned to you that 47% broadly writ of children and adults had atypical growth and maturation. But if we restrict our analysis to the children, it's more than half who had difficulties with growth or maturation. So it's a really important area for us as endocrinologists. I'm giving an example here of a case that has been published in the literature from Lynn Wolfe at the NIH that gives you a sense of something we can experience as well. So this is a case of an individual whose growth chart I'm showing, or is shown right here. So you guys are probably familiar with seeing this, but in your children's pediatrician's offices. So when I get asked to evaluate a child for decreased growth, actually I don't look at the height chart first. I first look at the weight chart. And I like to see what the pattern of weight gain has been, because one of the most common reasons for impaired growth that we see in endocrine clinic is inadequate nutrition, just because of how important energy is for growing. So if you look at weight at these dots, you can see at age 3 or 4, weight was actually around the 50th percentile, and then it started to fall, so just below that growth curve. And if you look at body mass index, which is a way of thinking about weight relative to height, this is actually better preserved in this individual, right? So body mass index weight relative to height is pretty typical, and yet linear growth, meaning stature, meaning how tall the child is. They were, kind of typical size around age 3 or 4, but then declined to below the line. And this was actually the first manifestation of disease in this individual, who by 11 years old also started to develop fatigue, another hormone deficiency, hypothyroidism, and eye findings that led to the diagnosis again of Kern-Sayer. So these are some data from CHOP, from our experience modeling growth trajectories in individuals with mitochondrial disorders. That's shown here in blue. So we have a growth curve for girls here on the left and boys here on the right. And I'm showing you average growth trajectory in patients with suspected or confirmed disease relative to a healthy reference cohort, the BMDCS cohort, and that average is shown in red. And this age here is on the x-axis and height on the y-axis. And one insight we have here from the curves that you can probably see is that short stature becomes more pronounced at puberty, because we find many individuals may not quite have the same or sustained prepubertal or pubertal growth spurt. So for girls, you can see the divergence in height starts to become more apparent around the time of puberty at age 10. And boys, you can see that as well. We also have looked at height and BMI Z-scores in our cohort relative to typical. This is an opportunity to review the concept of what a Z-score is. So you'll remember maybe from high school statistics, Z-scores refer to standard deviations above or below a population reference mean. So 0 in a Z-score is absolutely typical. 2 standard deviations above, or Z-score of 2, would be high. 2 standard deviations below would be low. So if we look at BMI Z-score and height Z-score in several different classes of mitochondrial disorders in children, you can see that actually in many of them, just like the case we showed, BMI could be preserved. In some, it's not. And some kids really struggle with underweight. But I think we do better with nutritional support than we used to. So we preserve kind of typical weight gain. But even in that setting, particularly in some subtypes, for example, mitochondrial DNA deletions, growth can really be impaired. Causes of impaired growth can include nutritional or GI disorders, as is written here, endocrine disorders like hypothyroidism or sex steroid deficiency. Growth hormone deficiency can exist, but this last point down here, stress or adaptation, I feel like the stress of the chronic condition is something that we invoke often and something that our data bear out, right? Because the body mass index seems less affected here than does the height. And when you think about stress and growth, one thing that I want to share with you is some research that our team has done around a hormone called GDF15. So you may be familiar with this hormone. It was identified early on as a potential biomarker of mitochondrial disease. It doesn't work perfectly in that setting because not all individuals with mitochondrial disease have high levels of GDF15. And there are other conditions that can make this level high. But you can see here, for example, controls have GDF15 that is lower, and individuals with other non-mitochondrial muscle disorders have lower levels, but the levels are higher in mitochondrial disease. And this is work from Rebecca Ganetsky. She's shown that particularly mitochondrial DNA deletions can have really high GDF15 levels that we think conveys the level of chronic stress in those individuals in particular. It may be that individuals with other forms of mitochondrial disorder, that this stress hormone just isn't as evident for reasons we don't understand. We know children with heart disease and failure to thrive have increased GDF15 levels. This is work from our colleague Li Ming Pei at CHOP. And so we wondered, this is also schematic from Li Ming, whether or not GDF15 is a hormone produced by heart and muscle that helps keep the body small to avoid the stress that's experienced by a larger growing body. And we know from animal models that GDF15 actually blocks the effect of growth hormone signaling in the liver. So we wonder, is GDF15 kind of acting to inhibit growth and keep a body smaller to make it easier to support that body with energy? It's really attractive to explore this hypothesis because GDF15 is a lab test that we can order clinically. And we can do that in our patients at CHAP by sending testing to the Mayo Clinic. And this is, again, work from Rebecca and Ibrahim, who showed that this is height Z-score here in both adults and children is related to GDF-15, meaning the higher the level of GDF-15, the shorter the individual. So I think there's something to that discussion that the chronic stress related to the condition can lead to less than optimal growth. So that those findings are summarized here. This is a question I get often, and I wanted to make sure to get to this slide, the growth hormone decision to treat or not to treat. So when growth hormone levels are low, short stature is obviously one potential consequence. Low blood sugar, fatigue, sorry for this typo, decreased muscle mass and impaired bone density, all of those can be manifestations of growth hormone deficiency. Certainly when we're asked to evaluate someone for this potential problem, we look for other causes of growth problems. We look at growth factors that respond to growth hormone. These include IGF-1 and IGF-BP3. I often now get a GDF-15 to kind of see where that is. And we sometimes perform provocative testing, meaning stimulation, to see how much growth hormone can an individual make. And then if growth hormone deficiency is truly present, then we have a discussion about whether or not to treat. So typically, and we individualize this discussion in our patients, if the growth hormone levels are very, very low, we think about whether or not a low dose of growth hormone would be helpful, potentially to improve growth if someone is very short, but also to take advantage of some of the muscle and bone anabolic, meaning building benefits of that hormone. One particular downside of growth hormone is it can increase blood sugar. So folks who might be vulnerable to diabetes should be thoughtful when growth hormone is started because blood sugars could go up. The other discussion we often have is increased growth rate going to be something that's difficult to tolerate by folks with mitochondrial disease, and should we be thoughtful for that reason? So a discussion in collaboration with the clinicians caring for the family, as well as, of course, the family and patient. I have a note here about adult growth hormone deficiency and the MAGIC Foundation, which is just a terrific patient organization, has, I think, a lot of great information about growth hormone for folks who are looking to read more. Switching gears again to bone health, individuals with low bone density can fracture, and one thing we teach our patients with mitochondrial disease who do have low bone density is fractures can be what is called occult, meaning they can have a broken bone without any particular trauma that they can cite. So we advise families that if folks seem really uncomfortable or have a new symptom, that occult fracture, meaning kind of hidden fracture without a really apparent trauma, could be on the diagnostic list. The way we assess bone density is by DEXA scan. And so a DEXA table I've shown you here. We have a picture of CHOPS, but I like the UCSF one better. It looks much nicer. So folks lie on this table for about 10 minutes, and this big arm kind of sweeps across back and forth. And DEXA captures density of the bone, not quality, so it's important to mention. So you can have a lot of bone, but if it's not put together in a strong way, folks can be vulnerable still to fracture. Fracture risk in any individual is very complex. So the muscle strength can increase risk for fracture. Exposure, people who do or don't play sports, for example, may be more likely to fracture just based on their activities. So we discuss fracture risk together. In adults, there is a tool that's used called FRAX that just kind of puts together risk factors. I think in folks with mitochondrial disease, this could be a starting place, but wouldn't be the end game. This is an important point to make, mainly for our pediatric participants, is that DEXA scans are what are called aerial measurements of bone density. But bone is not an area, bone is a volume. So size matters when we estimate bone density. And I've illustrated that by these 3 different cubes that have the same density, meaning the same amount of mass for each volume. But because of their different sizes, when we take a projection, when we take an aerial picture the way the DEXA does, they appear to have different bone densities. So that's why in pediatrics, we use a size adjustment to generate a Z-score for bone density and report bone density that way. Bone density changes throughout the lifetime. In children, we compare them to their same age peers also of similar height, because bone density is increasing throughout childhood and then reaches its maximal amount in the kind of early 20s and then declines. So in adults past age 40, we define osteoporosis as 2.5 standard deviations below the peak level, and osteopenia, meaning kind of moderate decrease, as 1 standard deviation below. And that's called a T-score in adults, and that's illustrated here. One of our other trainees, Shifa Gandhi, looked at all the risk factors we know of for poor bone health in individuals with primary mitochondrial disease that we were caring for at CHOP. And it will probably not be surprising that there's a whole range of factors that are present. So I'll go through them just to illustrate. Chronic illness itself is a risk for low bone density and low bone health. Immobility, not moving, because muscle contraction are what loads the bones to make them stronger. Malnutrition, acidosis, as might occur in some individuals with kidney disorders, diabetes, kidney disease itself, vitamin D deficiency, poor vitamin D absorption, some anti-epileptic medicines because they can affect vitamin D metabolism, and other endocrine hormone deficiencies. All of these together can affect bone density. And so one strategy, of course, to optimize bone health is to ensure adequate calcium and vitamin D intake. And there are absolutely non-dairy sources of calcium for folks who don't drink milk, but I just really like this graphic. So I'm showing you here to remind us all, calcium intake is important for folks working with a nutritionist. There's an Institute of Medicine guideline based on age of how much calcium individuals need in the day. And children can need actually more as they're putting down bone, as they're gaining bone. So one thing that we teach families when we're like, especially those who need more calcium, again, milk is not the only source, but is one. If you look at the label and you see that calcium here is 30% of the typical requirement, nutrition labels are based on a requirement for adults of 1,000 milligrams of elemental calcium a day. And if you add a 0 here, because it's based on that 1,000 milligrams, you can figure out how many milligrams are in the serving of food. So 300 milligrams, for example, here of calcium in this serving of food. So then we take the table on this slide and the nutrition labels and put together, gee, is this individual getting enough calcium to build healthy bones? And if not, we think about supplements. Usually we prefer to get calcium from food sources, but if that's not possible, then we think about supplementation. So to support bone health, balance, strength, and fall prevention are really key because it's not only about building strong bones, it's about preventing the falls that cause fractures. Exercise and PT, you're going to have a terrific talk by a PT later about exercise, and exercises, making sure those are bone safe. In some individuals, in adults and in children, medications to address low bone density may be indicated, so those are important to discuss with your physician. And especially for pediatrics, there are bone health specialists, and in adults who can help make the decision about medications in particular. I really like this paper demonstrating a benefit of yoga on bone density. So for folks who enjoy that as a form of exercise, we say go for it. Just a couple quick last few slides before we get to questions. I'm not going to go through in detail, but just to remind you from the starting slide that there's other hormone deficiencies that we as endocrinologists address as well. So sex steroids, meaning typically estrogen or testosterone, can occur in individuals with mitochondrial disorders related to deficiencies in sex steroid production often. Symptoms can depend on the patient's sex, but can include difficulties with sexual function or muscle or bone health. When we suspect someone may have sex steroid deficiency, we look at the pituitary hormones, FSH and LH, that govern sex steroid production. And then we look at the sex steroids themselves, estradiol, testosterone. The management, again, depends on the etiology, but replacement strategies do exist and can be really important for health and function. There are risks, of course, to hormone therapy, so we always want to individualize those treatment decisions. And Hormone Health Network has a lovely That's from the Endocrine Society, has a lovely guide. I know I'm spending a briefer amount of time on sex steroids, but for folks who are interested in reading more. Thyroid, we see a lot of folks where we assess for potential thyroid dysfunction. So I'm spending a moment here and also can direct you to the American Thyroid Association that I think has a terrific website and primer on various forms of thyroid disease. So the symptoms of thyroid dysfunction are really tricky because they're very vague and nonspecific, like fatigue, temperature intolerance, changes in bowel habits. Those symptoms are really common. So many folks end up getting thyroid testing, and thyroid disease is common in the general population. So it certainly co-occurs with mitochondrial diseases and can be more common in some. So typically we begin with thyroid stimulating hormone measurement as well, and which is the hormone from the pituitary that governs thyroid production. We also measure free T4, which is an active form of thyroid hormone. And particularly if we expect if we're evaluating for excess, meaning too much thyroid hormone, we can also measure T3. Management strategies depend. If thyroid hormone levels are low, we do have replacement forms. Other considerations that are really important, especially in mitochondrial disorders, are effects of illness and stress. So we have an entity in endocrinology called non-thyroidal illness, where similar to kind of the growth in GDF15 story that I mentioned, when the body is under a lot of stress, it has a lot of responses that can be adaptive at first and potentially maladaptive after a time on hormones that govern metabolism, one of which is thyroid hormone. So thyroid function tests are often abnormal when drawn in the setting of critical illness. And depending on the degree of abnormality, we might advise watching and waiting because we don't want to disrupt what may be we think the body's adaptive response to a critical illness by altering metabolism via the thyroid pathway. So this slide here illustrates the patterns of thyroid function tests that we get in a typical individual, high thyroid function and low thyroid function, either related to a problem with the thyroid gland itself or to the pituitary, just for people's reference. The last point I'll make very briefly is excess weight gain, which we know a lot of folks struggle with, and we could give kind of a whole talk on excess weight gain itself. So obesity is prevalent in the general population for reasons we both understand and don't understand. And some individuals particularly adults with mitochondrial disease, can also have excess weight gain. And this is a schematic from Grain Gorman and colleagues in Newcastle that I think is helpful to illustrate that one potential risk may be the exercise intolerance and difficulty with exercising, which makes movement more difficult, which of course can perpetuate weight gain challenges for many. So I wish we had an easy solution for this. We don't. If we did, you would already know about it. But really the components for excess weight gain and how to kind of address them for folks who've been successful at finding a strategy that works for them, we often hear about individualized nutrition plans. We think about adapting nutrition to the various parameters that are important to the individual. We talked about bone health, adapting nutrition to GI complaints and concerns can also help. And then physical therapy, we're going to hear from your exercise physiologist later. I think that's really important guidance too. I heard the discussion from Dr. Kara about NAD precursors. I'd agree with her assessment that these are really, really important to study. Niacin, and it sounds like she mentioned this paper as well, affected individuals with muscle performance with mitochondrial myopathy. We are studying NAD precursors as an adjunct to exercise therapy in individuals with free ataxia as a way to address potentially both exercise intolerance and diabetes risk. And so stay tuned to the results of those studies because I think this is a really interesting area of research. All right, so just to summarize, endocrine disorders are really prevalent in individuals with mitochondrial myopathies. And I think it makes sense to screen and treat appropriate people, and because we have interventions that can exist and make them feel better. Thanks so much, everyone, for your kind attention. I really appreciate it and happy to take questions.
All right. Thank you, Dr. McCormack. Yeah, we have quite a few questions. Are pituitary adenomas common in mito patients?
Do you know what's interesting? Pituitary adenomas are common in general.
Okay.
So Individuals with mitochondrial diseases may have more brain imaging than other folks might. So
Okay.
it can be a question of whether or not there are incidental adenomas that are found versus a true association. I think we don't know those details yet, but if they're found, that there's a good experience on how to evaluate them.
Okay. Can mito patients also have high levels of insulin instead of insulin deficiency and high levels of DHEA?
Yeah, thanks so much for that question. So yes, they absolutely can. And, I talked about insulin deficiency, right? But insulin resistance, meaning insulin doesn't work as well in tissues in the body, can be a cause of chronically high levels of insulin because the pancreas has to work harder, has to produce more insulin to have the same blood sugar lowering effects, if that makes sense. So the questioner yes, absolutely. And the
Okay.
DHEA question, I typically check DHEA-S, the sulfated form of DHEA. There can be a few reasons for high DHEA. One is chronic stress. So when cortisol levels are high, DHEA will go up also. Some women with polycystic ovarian syndrome physiology or excess weight gain can also have a high DHEA also.
Okay. This person was told that they have diabetes and to take metformin, which they have heard is bad for mito. Is that true? And if so, what should be taken?
So that is a great question. Individuals who I say there's very little in life that's 100%, but if anyone has a personal history of lactic acidosis, I definitely do not use metformin. And I often try to use an alternative to metformin in individuals with primary mito because they don't tolerate it well.
Okay.
It really depends. First decision is, do they need insulin or no insulin, not insulin. And then if not insulin, if they're adults, there are agents including like DPP-4 inhibitors, things that end in gliptin, and GLP-1 receptor agonists that may be appropriate, but it absolutely depends on the individual's other comorbidities and preferences. So yes, it's worth thinking about alternatives, I guess is the answer.
Okay. When having mito, what process would cause blood sugar drops with physical and cognitive activity?
Well, it's interesting. If oxidative metabolism isn't working as well, oxidative metabolism is the most efficient way to turn glucose into energy. So
Okay.
non-oxidative metabolism works too, but is less efficient, so may use up more sugar. So, the questioner's experience resonates with the experience of some of my patients who simply need more carbohydrate when they're undertaking those activities, if that makes sense.
Okay. Is insulin-dependent autoimmune diabetes ever caused by or associated with mitochondrial disease?
Insulin-dependent autoimmune?
Yes,
Yeah,
diabetes.
good question. So, first of all, we think, just I'm remembering the COVID question that ML got, like autoimmune mitochondrial disease, the mitochondria are everywhere. So folks who are studying the immune system and why it triggers pancreatic insufficiency wonder about that. We also think that those two things can co-occur. So some individuals with mitochondrial disorders may have autoimmune conditions, and so they kind of happen together. It's worth checking those antibodies to understand, though.
Okay. For a teen who eats by mouth and supplemental G-tube feeds and needs to gain weight, what rate of gain would be ideal? I guess that might depend on actually the person.
Yeah.
Loaded question.
But that's an awesome question, and hopefully the person has access to a nutritionist that can help decide that and individualize it
Okay.
for where they're starting from. Because there can be too fast too. There's something called refeeding syndrome, which happens if you gain weight out of proportion to like their ability to keep up with electrolyte and other needs. And so It is really important to go just enough and not too much.
Okay. This person's wondering if Rathke cyst is something to be addressed or negated and look for another reason of his weight loss.
Yeah, so some of, the questioners can absolutely talk to endocrine about the cyst itself because much depends. So the Rathke's, for folks who aren't familiar, can be a developmental phenomenon of a cyst within the pituitary gland itself. Some Rathke cysts are really tiny, some are really enormous and need to be drained surgically. So the size of the cyst is one really important determination, and its effects on endocrine hormone production. So I feel like talking to someone knowledgeable and getting that endocrine hormone assessment would be a good starting place to see if that's kind of the culprit for what the person's experiencing.
Okay. This person's asking, at what age would you suggest a bone density test for their child, for a minor child?
Do you know that person asked a question that we ask ourselves all the time?
Okay.
And so the briefest answer is we don't know what's most appropriate. We do know if anyone's had a fracture, especially something that could be atypical, that person almost certainly deserves a bone health evaluation that includes a DEXA. The current teaching is in children, don't get a DEXA unless it's going to change your management.
Okay.
And we don't routinely give bone strengthening medicines just based on numbers alone, but that practice is changing. So I think that warrants a discussion of risk. Like if a child is very, very high risk, sometimes we still do recommend thinking about a surveillance scan.
Okay. Is there a connection between autonomic system and blood sugar regulation?
There is, absolutely. So when blood sugar our bodies do not have lots of different ways of like responding to danger. Like the autonomic system is our way of responding to danger, that fight, flight, or freeze response.
Okay.
And the connection that the questioner may notice, when you're hypoglycemic, when the blood sugar is low, the autonomic system is one of the systems that fires to defend the blood sugar to make it go up. So that's why that sweaty, shaky, pale, fast heart rate, all that's autonomic system on overdrive. So I know some folks with mitochondrial disease experience dysautonomia, where the autonomic system kind of fires in ways that is unpredictable. The autonomic response to hypoglycemia is not right? It's appropriate because that's how the body typically responds to blood sugar that being low, but he's right to notice that connection.
Okay, I know our next speaker's on the line and I want to be cognizant of the time, but I just want to get through a couple more of these. Yeah. We have a person that says they had a total thyroidectomy 6 years ago for cancer, and my thyroid hormone levels have fluctuated widely since a number of times with odd results like high TSH and high T4 at the same time. Their endo was checking for HAMA, but if it turns out to be the reason for the fluctuations, are there any other tests you might suggest? Because her endocrinologist is stumped.
Yeah, that questioner, if you want to circulate, because that's a very specific post-thyroidectomy question. I'm happy, depending on the age, to suggest a thyroidologist who can answer that more in detail, because there are strategies, but probably beyond the scope of a quick answer, because it's a great question.
Okay. Are there any specific dosage recommendations for ALA or riboflavin?
That supplement dosing, I would defer to Dr. Carr and her colleagues. And I think the Mitoso website that she has some of the practice guidelines, as does Mitochondrial Medicine Society guidelines that suggest starting places, but individual specialists are also obviously best resources. Endocrine, we don't usually prescribe those.
Okay, got it.
Yeah.
All right, well, I want to be cognizant of our time, so thank you very much for being with us today.
Thank you to the group for the great questions. I really appreciate them.